after a scrumptious meal, we are here to debate. Debate about the common conditions that we all encounter. Debate about the questions that are usually raised. So welcome to the Maha Dangal in BOS Summit 2024. We are honored that to have you join us for this, what promises to be an enlightening and thought-provoking event. As practitioners and researchers in ophthalmology, we constantly strive to improve patient care through innovative treatments and advancements in medical technology. However, with progress comes debate, that all of us agree. Today we are here to engage in rigorous discussion to challenge established norms, to explore diverse perspectives on key issues that impact our practice and patient outcomes. Our speakers are distinguished experts in their respective fields, will present arguments and insights on topics that provoke strong opinions and drive our profession forward. This is an opportunity not only to listen, but also to engage, to question, and to contribute to the ongoing discourse that shapes the future of ophthalmology. So the debates we will witness today are not just academic exercises. They reflect the real-world challenges and dilemmas we face in our daily practice. So we'll start without much ado. We'll start the debate. For this, I will invite the jury, Dr. Mahabaleshwar and Dr. Madhav Honati, to please come up on the stage. We also have panelists in each subject, Dr. Gauri Murthy, Dr. Rajesh, Dr. Savri Desai, and Dr. Rekha G. Okay, so we'll start off the session. The first topic is cataract surgery alone versus combined with trabeculectomy. So we have a little bit of a switch here. Dr. Ashwini Shenoy will talk about cataract surgery alone, and Dr. Meghna Hiramat will talk about combined surgery.
Mic check. May I start, sir? Good afternoon to everyone who's chosen to be here. And I will be speaking today on cataract surgery in stable glaucoma. Basically, to let it be or not to be. We know that cataract and glaucoma are leading causes of blindness worldwide, and their coexistence is very, very common. We also know that cataract surgery may independently lower IOP, which allows for greater IOP control among patients with glaucoma, though combined phacotrab lowers the pressure much more, but it is not without its complications and may also compromise the success of both the surgeries. It is therefore important to compare the effectiveness of both these interventions to aid clinicians and patients in choosing the better treatment approach. So I'm going to have a small case discussion here. This is Mr. Stable Kumar. So he is very, very stable. He has had an established diagnosis of glaucoma. He's on treatment with medications, good compliance, free of side effects of medications, no progression noted clinically, structurally, or functionally, and no other ocular comorbidities. His IOP is in the range of 14 to 16 on maybe 1 or 2 medications, cup disc ratio of 0.6 to 0.7, couldn't be better. His charts are all in the right place, all planetary positions aligned. He couldn't be happier. And now he develops cataract. So now we have 2 options, cataract surgery or combined. So now we'll just discuss about what he wants. He wants quick visual recovery. He wants his IOP to be stable. He wants it to be minimally invasive, with lesser chance of complications, and no additional cost to the surgery. Though I do tell him that let's do another, procedures so that we can also address the glaucoma, because it is the gold standard reduction in progressive glaucomas. But at the same time, I have to tell him that the next day, we'd probably see a little more inflammation, visual recovery will be slower. In about a week's time, we'll both have to be thinking about shallow ACs, wound leak, hypotony. In a month's time, we'll probably have to also consider rising IOPs, a non-filtering bleb, malignant glaucoma, and in a year's time, we'll still be thinking about encapsulated blebs, failing blebs, blebitis, and the possibility that he's going to be back on his 1 or 2 medications. So do I need to rock this boat? Now, Stable Kumar's son is Google Kumar. So he's bringing me a load of reports, and I'm just going to very quickly go through this. So this is basically a 3-year study studying the effects of phacoemulsification and IOP with 3-year data. So they said 12%, 14%, 15%, and 9% reduction in IOP from baseline even at about 36 months. So that seemed great. A longer study, 3 and 5-year changes in IOP after phaco in open-angle patients, glaucoma suspect, normal patients, and even here it says at the end of 5 years, the IOP was significantly decreased in all groups, and the number of pre-op and post-op medications did not show any significant change. Now, is that only true for open-angle? No. A study done closer to home by Dr. Pandav and et al. Showed that in the entire spectrum of ACD, there was an overall 22% reduction in IOP. And is it true for all kinds of glaucomas? The answer is yes, it is. So this was a study done at AAO, and they showed that pre-op phaco IOP, and post-phaco IOP, pre-phaco medicines and post-phaco medicines, all of them showed a decrease. Okay, so is cataract surgery alone suitable in all patient profiles with glaucoma? Yes, because it does not change the established glaucoma equilibrium. There is scope for future TRAP in case of progression. It's reliable, speedy. So, of course, there are exceptions to every rule. We consider age, demographic, comorbidities, compliance, and stages of glaucoma. But all of that is out of syllabus because now we are talking only about stable. The truth is that our actions are testimony to our skills. So a cataract surgeon doesn't want to get their hands dirty with blebs, and glaucoma surgeons don't believe in the illusion of stability. Stability is but an illusion of time, so please choose wisely. Thank you.
Can I take it? Yes. Good afternoon to the jury and everyone present here. That was an excellent talk, Dr. Ashwini. But with all due respect, I would like to disagree. So why don't we opt for a phaco and a glaucoma surgery in stable glaucoma? Because why not? So let's discuss about the elephant in the room first. Stable glaucoma, what does it mean? So eyes which have achieved a target intraocular pressure and not showing any progression either structurally or functionally. But is there something more to stable than that actually meets the eye? So when we speak of glaucoma, it can be either mild, moderate, or advanced, and all of these eyes can continue to be stable, both structurally and functionally, provided the only modifiable risk factor, that is the intraocular pressure, is kept under good control. This at the cost of multiple topical anti-glaucoma medications proportionate to the severity of glaucoma. So here's a study which states that most of the eyes, despite being well-controlled pressures, do continue to progress. Up to 40% of patients progress to blindness in at least one eye in their entire lifetime. Now, we as ophthalmologists are to decide whether we're willing to take this risk by keeping our patients on medical treatment long-term. So discussing a study by Dr. Ravi Thomas, which was basically on IOP lowering effects in phaco eyes done in glaucoma. This stated that the probability of glaucoma to reduce an intraocular pressure by more than 5 millimeters of mercury is about 0.12%. In open angle eyes, there's a very minimal reduction, perhaps 2 to 3 millimeters, but this is highly unpredictable. And they also brought out certain important factors such as gonioscopy and the effect of medications being absent in most of these reviews, which claimed to bring about an IOP reduction post-phaco. On the other hand, in angle closure diseases, yes, of course, phaco does bring about a clinically significant reduction, but the probability of that being more than 5 millimeters is just 1%. And there is also a possibility of no change and even an increase in the pressures. Now, considering we have opted for just a plain phaco in our patients who are on medications, of course, so this is a study which is explaining the survival of medical treatment and the success and the mean time of treatment failure in these glaucomatous eyes which are on medications. So briefly, with the help of this chart, what they're claiming is, so eyes which are on one medication tend to fail at a period of 1.6 years. Eyes on 2 medications tend to fail at 1 year, and 3 medications, the time to failure is about 0.9 years. So eventually, we are going towards reaching the threshold for our medical management. So what is extra that this study is adding to us is that plan the surgical intervention to the patients has to be tailored based on the needs, the requirements, and the patient characteristics, their understanding of the disease and the chronic progressive nature of the disease, their compliance to medications, and their compliance to follow-up. So with a small example, a living example at our hospital, an 80-year-old patient who is a pseudophakic 15 years ago, and he's a POAG 20 years on topical medical management. So this is a timeline of his intraocular pressures for the last 15 years. Well stable on single anti-glaucoma medications. First time showed a progression 10 years ago, and there was a step up of the medications. Subsequently, progression noted again when we stepped up and also advised for a surgical intervention. However, patient was skeptical and refused at that point. He came back to us, and we had to convince him eventually to undergo a surgical treatment, and at the age of 80 years at this point. And all of this, so what are the changes we faced with this patient is that counseling, explaining to him as to why there was a progression noted, despite him being compliant with follow-up and medical management, fitness for surgery considering the age, his comorbidities and other factors, and the risk of surgical success in an eye, in a pseudophakic glaucomatous eye, which has been on topical medications for the last 2 decades. So here's a study which explains that there is a risk of external bleb scarring, and the chances of failure of a filtration surgery is likely to be high. And all of this was pursued to save this remaining field of vision that the patient had eventually. So finally, I'd like to conclude by saying that we have to tailor the treatment, individualize it for the patients, understand the patient characteristics, whether they are able to comprehend the nature, progressive nature of the disease, adhere to the medication, adhere to compliance to follow-up, and then give them an option whether they want to undergo a long-term medical management or opt for a more active surgical intervention. So to conclude, I'd just like to say, make hay while the sun shines, else all we are left saving is the tunnel vision for the patient. Thank you.
Thank you. Ma'am, please stay. Thank you so much. Both points, both perspectives, very, very, very well received. But we'll ask the panelist, Dr. Gauri Murthy, to give her opinion about it, and then we'll go to the jury. Can you give the mic there, please?
Thank you. It's a very difficult situation for me. Both of them are my students and colleagues, so I can't, antagonize either of them. And that is the truth even with respect to the choice. So like any debate, the points 2 and 4 have been excellently put forth by both Ashwini and Meghna. But eventually it is the patient in front of you which will decide what direction you're going to take. Let me make a qualification. A glaucoma surgeon is also a cataract surgeon. Okay, so one need not keep those two separate, but an overkill is also not advised where the patient is very stable with fully normal field and is on a single medication or 2 medications. Surprises are always there. We may find that such a patient eventually progresses, but what is very important is that you counsel the patient give them the options, and there is no need to unnecessarily fear trabeculectomy. See, that is the practical difficulty that I face. There are patients who have moderate to severe glaucoma with very significant field defects, and as soon as we say combined surgery, they are frightened because the perception that is given to them is that it is very complicated. So that need not be the case. So both the viewpoints are extremely valid, and it is the patient in front of us which will lead us to decide which path we are going to take. And whichever path we are taking, it's very, very important that the patient be a participant in this decision-making process. We can guide them, but we need to make them a partner as well. Thank you.
So can I request the jury to give their comments, please?
As has been mentioned by the speaker, we need to have a tailored approach, whether to do cataract surgery alone or a combined surgery. As mentioned by this speaker, it also means taking the demography into consideration. When I was in Middle East, Muscat, where I was a consultant there, routinely I used to do combined surgery because there is no way I can follow up them regularly. And if you say there's a second surgery, there's always a risk. So there I used to do routine combined surgery. But in this particular situation, in an urban situation, I would certainly recommend cataract surgery and subsequent follow-up in a controlled glaucoma patient.
Okay. So that was, I mean, I think all of us do go by the patient. I mean, all of us have the same intentions, good for the patient, but we need to tailor for each patient. Thank you, ma'am. Thank you, Dr. Ashwini and Dr. Meghna for this wonderful insights. We move on to the next topic, that is PDR. Do I inject or not? Debating the protocol is. For this, we have two speakers who were, unfortunately, because of the worldwide Microsoft shutdown, they were not able to fly to Bangalore yesterday, but we're going to have them on Zoom talk. We'll have Dr. Sachin Vasant Mahuli talking for injecting, and Dr. Jacob Chacko for speaking against injection. Can we have them, please? Dr. Sachin.
Hello.
Good afternoon, sir. Good afternoon, sir.
Yeah, good afternoon.
Yes,
Am I audible?
Yeah, you're very audible, sir. Thank you so much.
Okay. At the outset, I'd like to thank BOS and the entire team, especially Karthik, Ellen, and they've done a fantastic job. Unfortunately, I couldn't join because of the flight cancellations, but nevertheless, they have made us fantastic arrangements for online meet. Well, the topic today, which I'm going to discuss, is anti-VEGF in PDR, basically whether to inject or not to inject. Well, it's a very valid question for debate, and let's look into it. We always think that old is gold, but it's not true in our medical practice. We need to evolve, we need to change with the newer treatment, and we have to have an evidence-based medicine which keeps changing time to time. So lasers we've been practicing for like 1970s, and it's been still in use rampantly, and we have to have an open mind for newer form of treatments in PDR. PRP comes with certain side effects which we are all aware. Field loss, worsening of DME, worsening of TRDs, night vision problem, etc. And it doesn't provide a complete regression, and with limited set of laser, it needs a lifelong follow-up, and repeated lasers are required. Well, if we are going to debate on the cost effectiveness and the best treatment available, the debate is going to be futile. I think my colleague Jacob will understand what I'm saying. So let's see what protocol S of DRCR-NET. It's the largest study which has been conducted, and they have 5-year follow-up now. So what did we learn from the study is anti-VEGF alone as a monotherapy is a good alternative for PDR than in case of PDR with PRP. So it showed us that the complete resolution of NV was achieved in around 70% of the cases by end of 2 years. Better visual outcome when compared to PRP. They compared head-on with PRP laser and the injections. Lesser patients needed vitrectomy when compared to PRP. It takes care of pre-existing diabetic macular edema as well. What was the algorithm used was they gave a 4 loading dose and 2 additional for first 6 months, then 2 in next 6 months, 3 in the next 12 months. In case of DME, the total number of injections were 14 in 2 years. This was the assessment which they did, like, give the injections loading dose and assess every monthly. If the NV was stable or resolved, then no need to re-inject, just follow up on monthly basis. If it was not, if it is worsened, then add on the number of injections what you go on. So they did this for 2 years, and there were some cases which did not respond to anti-VEGF, which were taken up for laser later on. This is how the NV regression you can expect. This is the first picture, if you can see here. This is a large NV here. This is with the monotherapy, you can see the NV has disappeared completely. I mean, this is literally amazing. We don't see such results with the laser, because laser causes a lot of scarring, and we won't be able to follow up these NVs very well and document them completely. So this is what they understood, like on protocol S is like, the number of cases which they did. If you see, the worsened cases are very few on the top end of the bar there, and the failures are very few. There were a lot of patients who were stable, there were a lot of patients who improved, and there were lots and lots of patients who resolved. So how do we manage in the real world scenario is slightly different because of the pricing and the follow-up which we have to undertake with the patients in real world scenario. What I would do is I would give a loading dose of anti-VEGFs and follow up, and if there's a worsening, add on PRPs, and it becomes more cost effective, especially if there's a DME. It will help. These injections definitely help along with the laser what we are going to do in the future follow-up. So the question here is, we are not debating laser versus anti-VEGF. We are debating, do I inject or not? I would like to say I will inject, and I would like to inject in all the cases, unless otherwise contraindicated, like CRDs or a TRD which is threatening the macula. More importantly, we have to customize, individualize the treatment based on the response and the evidence what we have. We cannot just hold that I will do only monotherapy or I'll do only laser. That will be a futile discussion, but the point of discussion should be well taken, that do I inject? Yes, we should inject in cases of PDR. Either it's a monotherapy or you can add on laser later on. Thank you very much. I think the point was clear.
Thank you so much, sir. Thank you for your insights. Unfortunately, I think we don't have Dr. Jacob Chacko joined yet. Not yet. Next. You want to say something?
Yeah. Hi. Dr. Sachin and hi, doctor. And, and Dr. Jacob were supposed to join us today to be here physically with us, but because of the Microsoft issue, all their flights got cancelled. So they've been kind enough to speak to us on virtual platform. I think Dr. Jacob is taking some time to log in. He's having some issues. So is it okay if we go ahead with the next set of debate and then again come back?
Yes.
Yeah,
Yes,
sure.
please.
Thanks.
Thank you.
So I call upon the next set of debaters, Dr. Nagesh and Dr. Harsha. Can we have you here on the stage? They're going to talk about triple procedure versus stage surgery in Fuchs endothelial dystrophy with cataract. Of course, all corneal surgeons, this is something which really bothers us, whether we have to, put the cornea at risk or should we tackle the cataract first. So let's hear what both of them have to say. So Dr. Nagesh will talk for triple procedure, and Dr. Harsha will be talking for stage procedures.
On the outset, I would like to thank POS for this great opportunity. So when it comes to triple procedure, it is a corneal transplantation combined with the cataract surgery. Earlier, it used to mean penetrating keratoplasty with cataract, but now for Fuchs dystrophy, the penetrating keratoplasty is out of picture. We are only speaking about endothelial keratoplasty, be it either DSEC or DMEC, combined with cataract surgery with IOL implantation. So I have no financial interest in any of this discussants. So coming to Fuchs endothelial dystrophy, what are the indications for surgery? Any surgery for that matter. One, reduced vision, any significant cataract in these patients, reduced contrast sensitivity, increased glare, and early morning blurring of vision, which eventually clears by the afternoon or evening in some patients. So in these patients, first we have to decide whether it's a combined surgery or a cataract surgery alone. The specular microscopy, even though it shows lot of significant features, they are not a reliable indicators